Welcome to AETCM, the Emergency Medicine Channel. Today we'll be discussing a case of a young female who presented to our ER with acute abdomen. So can we begin?
Yeah.
A 40-year-old female patient presented to our ER with complaints of acute abdomen. So a little more detail into the history wise. This patient was suspected case of perforation, bowel perforation.
Okay.
So that's what the referral letter read. So in our initial 10-second assessment, patient was conscious oriented, was able to talk, but she was in a lot of pain. So quickly moving on to the primary survey, airway wise, patient's airway was patent. There was no pooling of saliva, no anatomical deformity as such. Breathing wise, patient's air entry was bilaterally equal and with adequate chest, but inadequate chest excursions, and patient was tachypneic. So with a respiratory rate of about 54 cycles per minute, she was only maintaining a saturation of 94% in room air, possibly secondary to intense pain also, sir.
Okay.
Circulation wise, she was tachycardic with a heart rate of about 134 beats per minute, and her BP was in a higher note of 160/100, but she was not previously known to have hypertension, again possibly secondary to intense pain. So, but all peripheral pulses were palpable. She was not in shock. So moving on to the disability part, her pain score was 9 on 10, severe pain, and GCS was full 15/15. Pupils were reactive. Now at this junction, we cannulated patient with two large bore IV cannulas, and considering the pain score to be severe, we directly went with paracetamol and opioid. So in this case, we gave a paracetamol of 1 gram IV along with tramadol 50 milligram and 100 ml NS. We gave it over a span of 10 to 15 minutes. Then we reassessed the patient again after 15 minutes because patient was in severe pain. Her pain score had come down, but it was still 6 to 7. So we repeated another dose of tramadol, 50 milligram 100 ml NS, and now she was little in a comfortable state. Her pain score had now dropped to about 3 to 4. So then we moved on, like we all did this like parallelly, sir.
Okay. So you have an 40-year-old female,
that's right,
who has come with an acute onset of abdominal pain to the ED, and in the initial assessment, his airway was patent, but breathing doesn't look good. The saturation was maintaining, but the respiratory rate was 54 per minute. So what are the interventions that you want to do at this point? 54%, 54 breaths per minute is the oxygen saturation, or is the respiratory rate, and oxygen saturation is 94%. So what are the interventions that you wanted?
One, we put the patient, since it was only 94%, we put the patient on oxygen. Nasal prongs, we put it at around 2 liter per minute, and saturation picked up, but she had tachypnea which did not resolve.
Okay.
Possibly secondary to anxiety, second because of intense pain that she was in.
Okay.
And also because of, because it was an acute abdomen, bowel perforation and all, that could have led to sepsis, and that again can lead to
Okay, we are not very sure what exactly happening to her breathing, but she is tachypneic.
Yes, sir.
She is tachypneic for sure. So you have supplemented her on oxygen. So one thing that you can, rather than starting her on a non-rebreathing, starting her on a nasal prong, you can start her with a non-rebreathing mask. We are not sure how much hypoxic she is at that moment without an ABG. Maybe 60-65 might be the PO2. We are not very sure. So the best practice will be to start with a higher amount of oxygen, then you titrate depending upon the requirement. So whether it is due to an ARDS, whether it is due to an aspiration, whether it is a sepsis related multiple inflammation, we doesn't know. So it's always better to start him on a high flow oxygen then to come down. So that is the intervention that need to be done for breathing. And what do you think about NIV for this patient, to start on NIV?
Sir, NIV, there wasn't a requirement in this patient.
If needed, you would have started?
No, not because it's an acute abdomen. So that will again increase a positive
pressure. So that is one of the contraindication for our NIV. In this patient, we would have definitely not started on NIV. And her hemodynamics was, heart rate was on the higher side and BP was on the higher side. It can be attributable to the pain. Right now, she is not in hypotension. Right. And the tachycardia can be due to the pain or due to the anxiety or multifactorial, or maybe to the inflammatory response, whatever she is having. Then she had a significant pain, she initiated on a paracetamol with opioid, a combination of paracetamol with tramadol he had given, and after that the pain score has decreased but still on a higher note. Okay, so what are the specific adjuncts that you wanted to do at this point of time?
At this point, one, anything important would be to check the acid-base metabolism. VBG was taken. VBG
we wanted an ABG here.
ABG,
It is not
yeah.
an VBG. It's a specific time that when you need an ABG. You wanted to know the oxygenation status. So you have to go for an ABG here. ABG is mandatory. Then ABG, what are the possibilities that you can anticipate in a blood gas?
One, because
What was the ABG finding of this patient?
this patient had metabolic alkalosis with a pH of 7.43, PCO2 was 47.9 and bicarb was 31.6.
PCO2 of?
7.43. PCO2 for 47.9,
Okay.
pH was 7.43 and bicarb was 31.6, possibly secondary to the abdominal condition.
Why are you
that she
saying
had.
it as a metabolic alkalosis?
Because 7.43 is again
Okay.
alkalotic,
Okay.
and then PCO2 and bicarbonate are both on the elevated, like
Okay.
40, 35 to 45. This is
See,
patient
PCO2
47.
47 for this patient who is 54 breaths per minute, who is taking a respiratory rate of 54 breaths per minute, and you are getting a 47 PCO2. That doesn't look good. When somebody is having a 54 respiratory rate, we are anticipating a PCO2 of much more lower limit. But she's having a 47. That means she's going for a respiratory acidosis. Primarily, she's going for a respiratory acidosis. Right now, she's compensated. She's whatever be the thing, she's compensated and holding on the pH. But it is more in favor that this patient will go in for a respiratory failure and you need to intubate her. That is the situation how the patient is going on. You just imagine 54 respiratory rate, 47 PCO2. If with this respiratory rate itself, the PCO2 is 47. So ideally, what all the metabolic derangement that you can anticipate in a blood gas?
Then since she is hyperventilating, so respiratory alkalosis would be what is expected because there will be PCO2 washout.
Yes.
But in this patient, PCO2, like you mentioned, is on a higher note. So
So that she's going for an impending respiratory failure. She's hypoxic. Her PCO2 have started building. If you are not intervening at another within 1 or 2 hours, she's definitely going to be on a ventilator. Otherwise, she is going for a respiratory failure. That's for sure. Then
we look for the other dyselectrolemias.
what are the common when you have somebody with abdominal pain? What are the common acid-base disorder that you will anticipate?
When metabolic acidosis itself.
Metabolic acidosis, how frequent you will encounter metabolic acidosis? See, somebody is coming with an intestinal obstruction, there is an increased lactate, you can have metabolic acidosis. You have other reason, you have increased lactate production and metabolic acidosis is a possibility. Usually what will be the metabolic alkalosis will be the picture. They will have some associated nausea and vomiting. So that will be the usual presentation. So they will have some amount of hypokalemia, secondary vomiting and metabolic alkalosis associated with abdominal pain. That is the usual presentation, but it all depends upon how the patient, what are the priority of the patient. Depending upon that, your acid-base disorders will vary. So what was the potassium for this patient?
This patient's potassium was normal, so 7. It was like on a lower note, but still within the normal limit. 3.5 was the potassium.
Okay. Now we have put 2 IV cannulas and you have given IV paracetamol and tramadol. You wanted to start her on fluids or not?
Yes, sir.
Why?
One, because she was dehydrated, because bowel perforation was already suspected. Oral intake was completely stopped for her. So IV fluids.
Our aim in emergency room, my question is, this patient is having 160/100 blood pressure and you wanted to start her on IV fluids. At this juncture, nutritional aspects, yes, maybe later you need to start her on nutritionally, you need to put her on either a parenteral nutrition or an IV infusion, whatever be the reason. But for this purpose, you need fluids to be started.
Yes, sir.
Why?
One, because hypertension was like secondary to the pain.
Okay.
She was not known to be hypertensive.
So what you have reassessed after 50 minutes, what happened to the blood pressure?
The blood pressure had come down to 150/90.
So still it is a normal, it is on a higher note only, there is no hypotension. So you wanted to start her on IV fluids. What is your take on it?
One thing is actually hyperventilation can cause dehydration. Hyperventilating was a long time, so it can actually worsen dehydration if he's on anything.
So what was the lactate in the ABG?
1.0.
So see, at this point of time, you are suspecting a bowel perforation. So bowel perforation, she is hemodynamically stable at this point. Why you want to start her on an IV fluid? preferably I will not be starting her on an IV fluid at this point, because once you are pumping in more IV fluid, whatever by the clot that would have occurred that is stopping the bleeding can again worsen the bleeding. So the standard dictum what we do in our trauma patients also holds good for a perforation here also. Unless and until it is definitely indicated, you start her on IV fluids. Otherwise, you can just wait. If there is any hypokalemia, you want to correct that, you can start her on an IV fluid.
Sir,
nutritional aspects at this point, no.
Suspecting bowel perforation, we have to keep the patient in NPO.
We can keep up. See, you are thinking in terms, the patient is in emergency room. This decision that we are taking is the initial half an hour decisions. I am not denying the fact that this patient needs an IV hydration. That need to be done later on. That IV hydration part, depending upon whatever we want to give on dextrose, normal saline, depending upon she is not taking any feed, you want to add on potassium to it, all those things you need to do. I am not denying the fact, but as a resuscitation point of view, at this juncture, it is not mandatory to start her on an IV fluid. That will not be our priority at this point. So putting on an IV fluid is a pretty straightforward thing, but we should be reason for giving an IV fluid for this patient. At this point, maybe you can wait and watch. You have better things to do rather than putting an IV fluid. You can have another painkiller for her. You can have a better pain assessment for her. Okay.
So this patient was continued to have to be maintained on NPO, and then we put a Riles tube too. This was what was done in the primary adjuncts. Along with this, ECG was also taken. And ECG only showed sinus tachycardia.
So why you want to put a Riles tube?
Riles tube, if a patient has intestinal obstruction that has led to perforation.
See, now we have as a primary objective, you said the patient was tachypnea, you put her on out to Riles tube. What was the indication to put a Riles tube? What you had any clinical suspicion of any intestinal obstruction?
It was an acute abdomen, so any bilious collection that can be like.
So for all acute abdomen, you need a Riles tube?
No, sir, not for all. Only if we are suspecting intestinal obstruction.
So we should have a little bit more history, right, in the background. We'll have some more history, whether there was any history of any constipation, any history of vomiting. When you are suspecting an intestinal obstruction, maybe there is a reason why you want to put a Riles tube. Unless and until you put an acute appendicitis, you put a Riles tube. No. Acute cholecystitis, you doesn't need. No. Here we are not very sure about the diagnosis at all. So we have to be very clear in putting a Riles tube. Riles tube, yes. You want to put a Riles tube when you are suspecting an intestinal obstruction, definitely yes. Maybe a perforation also, maybe an early perforation may not be needed, but later on to take away the secretion, maybe it will help some more diagnostic, but we have CT better available. So we can always delay putting a Riles tube. Okay, then what is the, can you complete the other secondary survey history?
So history wise, sir, she was not previously known to have any comorbidities as such, except for the fact that she underwent hysterectomy in the year 2019 for fibroid uterus, but her bilateral ovaries were preserved. Now, recently, about 2 weeks ago, she developed acute onset of abdominal pain, and which is why, but at that point in time, she did not have any history of fever, vomiting, constipation, nothing. It was just acute onset of severe abdominal pain. So when she was taken to a local hospital, in view of this, ultrasound was suggestive of left complex ovarian cyst with suspected hemoperitoneum. So on an emergency basis, that hospital took her for a bilateral salpingo-oophorectomy.
Okay.
Via laparoscopic method. So during that surgery, apparently it was uneventful and patient was shifted. 2 days later, patient did not pass stools and she was constipated. She had like 2 to 3 bouts of vomiting and again persistent recurrence of severe abdominal pain. Now at this juncture, they did a CCT abdomen which showed moderate pneumoperitoneum. So they suspected bowel perforation
and
patient referred here. So when we got the patient examination wise, patient was apprehensive to look at, but no pallor, icterus, all that examination was not there. So we moved on to the per abdomen system was what was checked first, and her abdomen was distended and she wouldn't let us examine her because it was too much of, pain intensity was too much.
So what do you call that?
Guarding, rigidity, all that was there. plus patient had diffuse tenderness.
Any discoloration over the skin?
Skin discoloration was not noted. So just the scars were there, that too of the laparoscopic surgery.
So it's a recent laparoscopic surgery. Post surgery, she developed abdominal pain, and they took a CT and confirmed it as a pneumoperitoneum.
That's
So
right.
there is a clear-cut, straightforward case. So she need to be she need to be intubated, taken to the OT for further exploration, and in the ED, you need to start her on a broad spectrum antibiotic.
Antibiotics.
That will be our aim here. But what was done for her then?
So in this patient, apart from pain management, we started her on antibiotics. We had, since it was a GI contaminated perforated injuries, so we had to start her on a broad spectrum antibiotic, which is why in this case we took a meropenem. There are many regimens that we can follow. A single agent would be a peptaz or a meropenem that can be used. We use 1 gram meropenem, but if you want to use the combinations, we can use cephazidime.
See, since this patient is already referred from another center, we went ahead with meropenem. So that was the reason. Otherwise, a third generation gram-negative, third generation cephalosporin with metronidazole will be enough. So the idea will be you need to think of anaerobic coverage also. So the gram-negative and anaerobic coverage. So these are the two organisms that we have to consider: gram-negative, anaerobic coverage. So ceftriaxone, cefpiraxone sulbactam with metronidazole will be the below the diaphragm. So metronidazole is the anaerobic coverage of antibiotic of choice. So then she was intubated in the ED?
She wasn't intubated. So immediately a GI surgery consultation was placed because this patient had to be mobilized from the ER at the earliest for exploratory lab. So it was a call slip. Basically, we posted her for surgery, exploratory lab right away.
Okay.
So the priority was to shift the patient as early as possible. So in the ED, what we did was to manage the pain. We put the RT and the fluid, maintenance fluid we gave in. Gave
and antibiotics were started. See, this is like a sick patient with already a referral that is coming to you being shifted. But just remove that all the surgical history. So somebody is coming with an acute abdominal pain. So after your initial assessment, what will be the investigations that you wanted to send? Just leave about this patient. What are the investigations?
In this case, because it's peritonitis, causes of peritonitis.
See, don't think about peritonitis at all. Somebody has come with acute abdominal pain to the ED. A 40-year-old female. Imagine a 40-year-old female with acute abdominal pain in the ED. You have done your pain management, and rest, how will you go about?
So since she is in a fertile period, UPT has to be done.
Okay.
But in this case, there wasn't suspicion because hysterectomy was already done.
Okay, leave about this patient. Just think about a fertile female coming to the ED.
Ectopics has to be ruled out, ruptured ectopic.
First.
So UPT has to be done.
Which one? X-ray abdomen erect.
X-ray abdomen erect. Okay. So what is your comment on X-ray abdomen erect? How will you do an X-ray abdomen erect? What is the sensitivity and specificity for an X-ray abdomen erect? And how good is an investigation in the era of an ultrasound and CT?
As initial, this investigation shows actually we can do it for ruling out any intestinal perforation, obstruction, and also any air under diaphragm.
Okay. So what you wanted the patient, ideally when you are going for an upright chest X-ray, you can ask the patient to sit upright for the first 15 minutes. Just don't send the patient directly away for an X-ray. You can ask the patient to be in upright position for the first 15 minutes and after that get an X-ray. So the yield will be much better. Sensitivity ranges from 50 to 75%. So if you ask them to sit up like this for 15 minutes, you will get a better X-ray. That is one. Then what are the other views that you can do?
If they are not able to do, we can go for a supine or a lateral.
Lateral decubitus view. That is the next one that you can think of. Lateral decubitus view and upright X-ray. Again, our idea will be to look for the gas under the diaphragm. So that is one investigation. Then investigation number 2.
So we can go in for a urine routine.
Urine routine examination. Okay, routine examination, definitely you can consider urinary tract infection as the one of the differential diagnosis.
Bedside ultrasound.
Bedside ultrasound.
Free fluid, to see any free fluid in the bowel.
Okay, you have to look for cholecystitis. You can look for your appendicitis, ureteric colic, free fluid, and from life-threatening to simple diagnosis we can make. So the investigation, the next thing that you wanted is an ultrasound abdomen. So suppose a patient has come, our priority will be pain management. Pain management followed by you need to have a diagnosis. For diagnostics, depending upon the scenario, whether you want to go for an X-ray, all patient needs an X-ray, no. It all depends upon your clinical expertise. If the patient is already on an aspirin, multiple drugs, an elderly man, you are suspecting a perforation, there is a guarding rigidity, features of peritonitis, definitely yes, an upright X-ray. But you think it is mostly an isolated one. Either it is a cholecystitis or it is an appendicitis, or it can be an urolithiasis. Maybe an X-ray KUB with an ultrasound will be more than enough. The next thing, when you are not getting a diagnosis, then you need to think why. Still, elderly age group, what are the red flags that you need to consider? An elderly
Malignancy has to be ruled out.
Malignancy, elderly, triple aortic aneurysm, that is another deadliest thing that you can miss in an ED. Triple A can be definitely need to be looked in for. So these are all depends upon the age and the presentation. What are the associated features? So the investigation that you should be doing will be an ultrasound, the plus or minus CT depending upon the severity of the disease, and definitely an antibiotic may be warranted depending upon the signs of inflammation. So you go with your Alvarado score or whatever be the score for your appendicitis, cholecystitis. If you suspect cholangitis, whatever be the reason, gram negative is a must. Anaerobic coverage depends upon your further whether there is any chance of contamination. Definitely anaerobic coverage needed to be done. And pregnancy, urine pregnancy test is the one thing that we need to always think in terms of a female patient coming to the ED. And pain management. So the WHO pain management triangle, starting with your paracetamol, weak NSAIDs, weaker opioids and opioids. And always think that you can add on an colic agent, anti-colic agents like diclofenac, and all those things you can add on so that it will help to relieve the pain. So acute abdomen, it can be a straightforward uretary colic to an, like what you have mentioned, very bad peritonitis with perforation, but here it was already diagnosed. So it was a straightforward case for us, but otherwise it would have been a difficult this time. Okay, anything to add on?
Nothing, sir.
Okay.
Her post-operative period was
Patient is fine. They have taken for laparotomy. So they have done the resection, colostomy.
Yes, sir. Laparoscopy, exploratory lap was done. Then about gross fecal contamination was found, about 500 ml with intestinal adhesions was seen.
Okay.
So all that was released. Patient's abdomen was cleaned and then she was shifted to the ward.
Shifted to the ward. Okay, fine. Thank you.
Thank you, sir.
Okay.